with your next presentation. Put your slides up on ethics. And we have the slide presenter there. We'll get your slides up.
Okay.
And you have the clicker.
My clicker, thank you.
Clicker.
Okay.
Perfect.
Okay, well, Joe asked me to speak about ethical considerations for allied health professionals. And when he asked me to do that, I was like, why are you asking me? I'm not a professional ethicist, ethics person. But I told him, okay, I'll talk about.
But you have a lot of ethics. And
it's a journey.
High moral standards.
It's a journey. And I think for me, these are things that are, so I have no conflicts of interest or things to disclose except to say that questions that I have are more directed at myself, and hopefully we can have a discussion when we get going. So I've been back at the Texas Heart Institute. I've been an instructor on and off since 1983 when I trained, and I am now there full time. And since I've been back, each perfusion class that's come, I've asked them, what does professionalism mean to you? So that we can kind of develop a pillars of professionalism for each class, and they can hold themselves. And I'm just listing some of the ones they've come up with, and this is over the last 3 years. Lots of different descriptive words for what encompasses being a professional. What was interesting when I went back and looked at the collection of words, ethics or ethical behavior, though some say one of the gentlemen that just graduated, golden rule was his word that he picked. But ethics is very rarely chosen. And so maybe they just feel like that's encompasses all of this. So maybe I should change it to mean, what does ethics mean to you? Joe asked me to talk about this, so I went back and was like, okay, what does ethics mean to me? Definition-wise, philosophically, the study of our morals and values, and of course, what's right and wrong, what's good and bad, what's virtuous, and what are our vices, and obviously our ethical behavior professionally sometimes comes into conflict with what our ethical or moral compass is for ourselves. My moral compass for self is grounded in, my church, my upbringing with my faith, and my grandfather, who told me that your handshake is everything you have. Your word is your honor. And if you lose that, then you really aren't worth much. We came from humble place in Kentucky, and that's pretty much what you had, and some good moonshine. So my brother shared with me a couple of quotes from famous people, and he likes this one: relativity applies to physics and not to ethics. The other one, which I can kind of relate to, is ethics is the activity of a man directed to secure the inner perfection of his own personality. Now, the person that impacted me and my beginnings as a perfusionist was Charlie Reid. He was the program director when I was accepted at the Texas Heart Institute. And he was a very interesting and charismatic man. This is a quote from Dr. Cooley about Charlie. And yes, Charlie was abrasive, autocratic, and very severely disciplinarian. He was very hard on us. But he was also a poet. He was a writer. He was an artist. He loved to grow violets. He loved flowers. He loved to travel. He loved a really good cigar and a really good scotch. He was a... Yes, he did.
You left that out.
And you liked it. Yes, he did. He was a very complex man, but he, and I'm not saying he was ethical. This quote by Abraham Lincoln, I think, surmises Charlie, in that, in my experience, that those with no vices have very little virtue. He was passionate about perfusion, about professionalism, about our responsibility as professionals and the development of our profession, and that we would be recognized in that. And so for that, you know, Charlie needs to be commended. And he did, you know, show me that we needed to be passionate about our patients, and that comes first. Safe perfusion practice should always come before self. And he showed me that, you know, some things I didn't want to develop into. And my mentor, Nancy Yanez Hicks, was a really good friend of Charlie's. And Nancy, if you're listening, you know, I love you and I'm appreciative of your guidance. But anyway, so Charlie touched me in profound ways, and I'll leave it there. So the history of the code that medical ethics and Dr. Bhatia has to go by dates back to the 5th century before Christ. We all know the Hippocratic Oath. In the 1800s, the Code of Medical Ethics developed into a standard. And when I was reading this, it was interesting because in the beginning, and you may be able to speak on this, the code was not only how physicians treat patients in the hospital, but it also talked about how patients were supposed to deal with physicians. And is that still in the Code of Ethics?
It may be there, but it's not followed very.
So I thought that was really interesting. So this is, you know, the medical ethics code is a living document and does evolve with the changes in medicine and our society and what our moral compasses are. And there are going to be ethical dilemmas and changes as we move forward. But I think we all need to reflect on what is our code of ethics for ourselves as a professional, as well as how that comes into play with our own personal moral compass. So it's more about not only just rules for acting and tools for how we behave, but also thinking about the challenges that we face as clinicians. So as perfusionists, we fall under several ethical standards or ethics standards, one being our American Board of Cardiovascular Perfusion, which has ethical standards with about 8 different standards, and it's geared towards professional behavior and adhering to our certification and recertification. So any certified clinical perfusionist is bound by that ethical standard. And it's to protect the certification, that's our competency, and that we're trying to protect the patient. But being certified clinical perfusionist is voluntary, even though we all feel like we have to be certified, and hospitals want us and our surgeons want us to be certified. It's not mandatory that you're certified. In the state of Texas, if you're licensed and had grandfathered in, you don't have to keep your certification. So
Really?
you know, so I don't know if you've read the ethical standards for the ABCP, but if you haven't, I would encourage you to go on the website and review the ethical standards.
No, I haven't read it. Yes, I will.
Okay, thank you. Okay, not sure if everyone knows that the perfusion curriculum for perfusion education programs does have a unit that is based on ethics and ethical behavior, and so it is taught in the perfusion curriculums. I know Terry Crane, the program director and my mentor, and has gotten phone calls talking about, don't you teach these young people any professionalism and, you know, their work ethics and these millennials. And so I wanted to make sure everybody knows that is part of their education process. And we do talk about professionalism. We talk about ethics and research, both clinically and in the research lab with animal studies. A lot of discussion now about ethical dilemmas for Ecmo and transplant patients, artificial devices, which I think will be something that as we go forward with that technology, will be questions and ethical dilemmas. End-of-life issues, how to deal with that as a young person. People coming into perfusion, not all have been in healthcare before, and so they need some guidance on how to deal with those things, because it is traumatic when it's the first time and you're told to turn off the Hotline machine, especially when the patient's still awake on ECMO. So we do talk about those things. We're very fortunate to have our attendings, physicians, anesthesiologists that will come in and actually talk to our students. So that is part of the education process. Okay, so another code of ethics that perfusion are held to are the AmSECT code of ethics. And so if you're a member of AmSECT, then you are bound by the code of ethics for AmSECT. What I find kind of sad is that not a majority of acting perfusionists are members of any of their professional societies. So if you're not a member of AmSECT, then the code of ethics for our members aren't binding to perfusionists. Versus, do you have to be, I mean, is it voluntary to be a member of the AMA or STS?
Voluntary.
It's voluntary.
Yeah.
So then it goes back to what's your personal moral code of ethics. So if you don't want to be part of AmSECT, maybe you need to develop your own, okay? And the biggest part of all of these, and I'm not going to read them all to you, is that your responsibilities are to the patient and the trust of the patient. So there's several canons of the AmSECT code. And again, I'm not going to read each one to you, but each one of them I kind of reflected on and questions about myself and practice and things that I've encountered. And so I hope that after this discussion that people will share their feelings or, you know, challenge or call in and ask. But the first canon is geared towards protecting and safeguarding the patient when there's unethical actions or incompetence of any person that's taking care of that patient. So for me, what would you do if a perfusion colleague was impaired during cardiopulmonary bypass? How would you interact? What would you do if you knew that that patient was that perfusionist was impaired? Would you tell someone? Would you take over? Would you be silent? And those are hard questions to answer. And I think all of us in this room can probably think of a time where we've been in a situation like that. The second canon deals with confidentiality, the patient's clinical information, and that we're to protect the welfare of that individual in the community. And I think we can all probably attest to being asked for patient information for a family or friend, that we weren't a direct caregiver for that patient, and therefore we shouldn't be reading people's charts or sharing information about a friend or family member. And this has happened, especially when we work in places like the Heart Institute or New York Pres, where famous people are operated on, and everybody wants to know, you know, what happened with that patient. And I have a friend that was at New York Columbia Pres, and she was the perfusionist for a former president of the United States. And I have gotten zip out of her, so I can.
Bill Clinton.
Not saying who.
Only one that was there that got operated on.
Hippocratic zip confidentiality.
Which is actually kind of funny because the surgeon I worked for that very next day was a resident there, and he told us exactly which grass got put on.
No.
Yes.
That's
yes.
See?
The surgeon was Craig Smith, right? Dr. Smith, I believe. Anyway, go ahead.
I don't know.
You know more than you're letting on. I see it. I could tell.
Okay. The third canon from the AmSECT Code of Ethics deals with members should provide only services for which they are qualified. Members shall not misrepresent in any manner, directly or indirectly, their skills, training, professional credentials, identity, or services. So this I reflect on, do we step out of our scope? I know when I was trained, again, Charlie told us never step out of your scope of practice. You are trained as a clinical perfusionist. You are not an anesthesiologist. You are not a cardiologist. You're not a cardiothoracic surgeon. If they ask your opinion based on your perfusion training, you need to offer that as the expert. So do we step out of our scope? And have I stepped out of my scope, especially when it comes to interjecting drugs that we give on pump? You know, we're put in situations where anesthesiologists leave the room and we're required to, are we trained to really do that without direct supervision? Now we can say the surgeon's in the room, and so I always talk to my surgeon as far as that. But when we're thinking about other things that perfusionists do, and you know, now Ecmo is being managed by clinicians that are not trained perfusionists. Do you think that supportive personnel should be initiating Ecmo without direct perfusion supervision? And that's a question I have to ask myself, because you get into the balance of we don't have enough perfusionists, so we're going to train our respiratory therapists and they'll be able to run this equipment, and we're supervising. So what is supervision? Do we need to be there, or is consulting considered supervision?
So I know Joe's writing notes because this very presentation was given at last year's meeting about having nursing, respiratory therapists help run these types of programs without, like Joe.
No, that's yes. That's,
Yeah,
I mean,
no,
I think
yeah.
that now read the statement. Can you go back to Canon 3? Yes. Do you think supportive personnel should be initiating ECMO? There's a big difference. We'll get into this during the question and answer. Big difference between initiating ECMO versus without direct perfusion supervision than what they were talking about, which was monitoring the system after it's been initiated and the patient is stable. There's a big difference between the two, but we'll get into that. We'll talk about that later. Go ahead.
Well, because it's moving to that, and you know, even where I'm a PRN perfusionist at a facility in Houston, and the team is moving towards. We had a hybrid team where it's perfusion, nurses, respiratory therapists, but now moving towards where perfusionists aren't going to be present in initiation. And it's like, it's a dilemma, because it's like, okay, I don't want to come in at 3 o'clock in the morning. Yes, I need to come in at 3 o'clock in the morning because I feel like I need to be there. But
what you say, Joe, is yes, you're allowing somebody to monitor, but according to that statement, it says members shall not delegate to a less qualified person any activity which requires skill, knowledge, and judgment of a formally educated perfusionist. So you are delegating observation and monitoring that under normal circumstances would be done solely by perfusionists to now a qualified nurse or a nurse or a respiratory therapist.
I take the respiratory therapist off the table with me, because
Okay, that's anybody
not
that's not
a good qualified
anybody
nurse.
that's not a perfusionist, though.
But I think that's an issue. I think, and again, I don't want to, we're kind of jumping ahead, but delegating the responsibility to them, I think a blended program, I think there are, and you mentioned the key word, which was trained. So a lesser qualified implies that they have not been properly trained in order to perform the function that they're performing. But if they are trained and they are competent, just because they're not a perfusionist doesn't mean that they're not competent.
But that's not what our statement says. Our
no,
canon
I understand.
says.
I understand that's what it says. I disagree with it, but that's what it says. Okay, I concede that it says that.
And
I disagree with the statement.
I mean to interrupt, but this is really pertinent to that presentation that was given at the last year's meeting involving this exact scenario.
I agree 100%. I mean, I think you're absolutely right. It's going to be a good discussion. Please go on.
Okay. Our fourth canon is regarding members shall strive to improve their medical knowledge and skills on a continuing basis, and members shall support quality didactic and clinical education.
Which means they should all be watching this
Yes.
right now.
Yes. We should participate in educational activities which enhance our knowledge so that we can provide quality healthcare to the patient. And so reflecting, do we as professionals, professional perfusionists, continue our education because we're seeking knowledge, or do we do it because we have to get CEUs that are required for our recertification? And would people attend national conferences and listen to webinars if they didn't need the CEUs?
Mhm.
Would we read a medical journal if we didn't need a point for a CEU? You know, I'd have to challenge myself. Again, we were told you need to read at least, an abstract, an article. But if we can't, if we're not doing that, and I'm talking about self, I'm not talking about anyone. So that's I think that's something we as perfusion professionals really need to think about, especially if we're making changes, which is the next thing, changes in our clinical practice. So, and reflecting on, are we mentoring our future? Are we sharing our knowledge? Now, I think about the people that mentored me, and for those of you listening, are you mentoring young professionals right now? And if not, consider doing that, because we need to pay it forward.
Or if they're young, are they seeking out
Right.
someone to mentor them? Because I remember the second year out of perfusion school, I just thought I knew everything. And I left a great job, which I wish I had stayed at, in Nashville, Tennessee. Took a job as a chief up in Connecticut, and because after 2 years of being a perfusionist, I could be chief, and I got fired after 2 months. So it didn't work out too terribly well for me. But I think younger people need to also find someone who is willing to mentor them, who is willing to sort of be a good guidepost for them.
Yeah. I mean, when I went to Herman from Texas Heart and I was the chief, I didn't know what I was doing, but I was, I called Sharon Walden all the time. I called Mark Cruz all the time. I called Aaron Hill all the time. He didn't even know who I was, but he'd answer my questions. So, I mean, it was, because I didn't want to hurt anybody. It was, anyway, it was, so you're right. Okay. The fifth canons discusses members that maintain and promote high standards for perfusion practice, which may include education, research, and scientific presentations or publications. We need to participate in continuous quality improvement. And do we do that as perfusionists? And do we practice that at our institution? Are we involved in research? And if so, are we doing it in accordance with ethical and standards that are set by Joint Commission or your IRBs? And are we developing valid research that meets the standards, that we're not frauding or plagiarizing work? It's hard sometimes when you're a small community hospital to be involved in research, but I think we can contribute even by developing our own continuous quality improvement wherever we are. And so I challenge myself to do more of that.
Mm-hmm.
Canon number 6 talks about members at all times should hold the well-being of the patient to be paramount and shall not act in such a way to bring the member's interest into conflict with the patient's interests. So, interpretive statement, the perfusionist will always attempt to fairly evaluate all competing products and services with the principal selection criteria being that of the regard for the patient's safety and well-being, basing selection on documented clinical and scientific data. And this one I think we all need to reflect about. Are we making changes in our perfusion practice and selecting products that's based on documented clinical and scientific data? And are we at a point in our perfusion process where we shouldn't be making changes in our perfusion practice without it being reviewed by Institution Ethics Committee or the Investigational Review Board. I know that I'm working at centers that's made some pretty big changes in their clinical practice, and the surgeons weren't included in the decision, which I find disturbing. So this is a paper I found from New Zealand talking about changing practice, how we cross the line. And when is it not obvious when formal research methods are required before changes should be made, or when should change be made justifying simply on considerations of principles and common sense? I know in the 80s, when I started as a perfusionist, we made lots of changes based on, okay, the blood is squirting out there, or there's stuff floating around in the reservoir. We probably need to use, a pre-bypass filter. We probably need to use a arterial line filter. But today, should we be changing things, big pieces of our perfusion practice, without doing some evidence-based research? And this last paper was just published in Perfusion about dishonesty in science, and talking about the number of scientific articles that have been retracted just in the month of April. And so I think for this is just for me to reflect on reading with a critical eye and not believing in changing practice just based on something that's published, and actually then having a conversation with the whole team and, studying and validating. And as a clinician, and I look at how many people are members of AmSECT, and now we have standards and guidelines that are guiding our perfusion practice, yet less than 50% of our practicing perfusionists are members of AmSECT. So we're not contributing to developing those standards and guidelines. So how do we make sure that what we're doing is the correct thing if we're not even speaking, or we're not even having any input? And again, I'm not pointing any fingers at anybody. I'm talking about self.
So who gets to decide what those guidelines are?
Wait till we get to the question, but good question.
So this is something that Terry Crane tells us every day, and guidance. Integrity is doing the right thing, even if nobody is watching. So I leave that to you all, and thank you very much for your attention.
Nobody's watching.
Thank you.
Excellent. Very good.
Appreciate
Very good job. Okay, so let's open the phone lines. And Magic, did you get my text that somebody said somebody's been trying to call in, and that nobody's answering, that it's not working? So we're going to check the phone line first. Oh, yeah. Look, somebody did try to call, but it didn't. I don't know why it didn't. I don't know why it didn't work. So something's wrong there. So we'll have to. Well, I'll even call them back. Okay, I'm gonna call them back. Let's talk about a couple of things, and would like you to participate in this too, and our other panelists, Stephanie and Rodell, and the audience. Oh, you had a question. The audience had a question. Vic, what was your question?
Who gets to decide what those guidelines
Okay,
are?
we can't hear you.
You
okay.
want to just repeat what I said?
Yes, so the audience said, who gets to decide?
What those guidelines are?
You mean those canons?
Yes.
Yes, okay, so the question is, who decides what the canons are?
The membership of AmSECT, as well as the leadership, the executive leadership, develops the ethical standards. And so I just rotated onto that committee a year ago, and they changed very so slightly. But for our standards and guidelines as far as practice, based on evidence-based practice that has a collaboration of perfusionists, surgeons, anesthesiologists that have been collecting data. A lot of it came out of Boston, the perfusionist in Boston have
Mhm.
collaborated a lot. And so standards that the STS has developed as far as temperature management, blood conservation. So a lot of those standards are now being encompassed into our standards and guidelines.
So I think what you're saying, and I want to make sure that I answer the question for you completely in the audience, is very few. It sounds to me anyway that very few people. You're on that committee though, but very few people are actually deciding what those ethical standards are. I think they're good standards. Don't get me wrong. I'm not criticizing the standards, but it's not really the membership that
No, it
creates
is the membership, but you have to vote, and that's the problem. If you're not a member, then if you're not speaking, then you can't, you can't help change anything. Or if the standards are the go to vote.
Mhm.
Like recently, as the standards and guidelines for pediatric perfusion practices went out for a vote.
Mhm.
But if you don't vote or have a comment or involved in developing, then you can't really be upset about what the standards
Mhm.
are.
So the standards are
People to vote for their president.
the standards are created, and then those are sent by a group, and then it's sent out for vote,
Mhm.
and then they're ratified based on the vote.
Yes. So,
That's how it works.
so if we don't want that, then we can speak and say, no, we need to change that, or we need to have a discussion about that.
Mhm.
But
Who's we?
the
The-
membership of
Okay.
the professional organization.
Okay.
And that's where I'm
So I don't even know what that process would be.
are you a member of AmSECT?
No. But I wouldn't know what that process would be.
What's
I
interesting?
mean, I've been a member, and I'm not a member, but Bill's gonna be here tomorrow.
Okay,
We're not here, but
yeah,
he's gonna be here tomorrow. I think we're gonna have a very good conversation.
So I
but
think we should address that
it's-
with him tomorrow. A forum like this where you could have a conversation
Mhm.
with members,
Mhm.
and discuss. Like people could call in, ask questions. I think that would be very helpful.
Mhm. I think so. I think it would be too. I think, yes, it would be. And I do think that the dynamic is somewhat more complex than just as simple as, I'm not a member of AmSECT. It's more complex than that.
Yeah, it
And
is.
I think that,
you're absolutely right. It's much more complex.
Because I'm
than
not
that.
the only person that's not a member of AmSECT. As you said, it's actually far less than 50%. I do think that are you a member of the STS?
Yeah.
Okay, so, and I think there's a lot of perfusionists who are members of STS that aren't
Right.
members of AmSECT.
Well, I think that's
And
great.
there's
You don't have to
reasons
be a
for
member
that.
of AmSECT.
No, I think you
just
should be.
You should be a member of something, of a professional organization.
Mm-hmm.
We want to call ourselves professionals. And again, Dr. Batias, I'd like your comment on this. Yet we choose to not participate in. I'm not saying you have to be a member of AmSECT. STS, there's the academy, a local or a state organization. I'm not saying that you have to be a member of AmSECT. I personally, and I made excuses why I didn't want to be a member of AmSECT. I went a whole decade not a member of AmSECT because I didn't agree with who was the editor and was also officer, and I felt like it was a conflict of interest. But I've decided that I can't make any change if I'm not participating.
Mhm, mhm, mhm.
So I'm not saying you have to be a member of AmSECT. You're a member of STS. You're a member of the Academy. You're a member of you're sharing your knowledge here. I think I'm more of saying we need to participate.
I agree with you, and I'm not. This is not. I have no anxiety over this. So
I know
I
because
don't
we
want
talk
you to-
about it a lot.
we talk about it a lot. Okay, let me call this number. This person who is trying to call. How do I make it? Does anybody know how to make this work?
Yeah.
Because I can't figure it out. I'll swipe to unlock. Okay, but then it just locks itself again. It's just I can't figure. Here, somebody help me. I can't do it. It's like the tweeter. I can't do that either.
The tweeter.
Tweeter.
It's Twitter. It's Twitter.
It's
Twitter.
they
Twitter.
keep trying to get me to say it wrong. I'm not going to do it.
Okay.
What do you do? What do you do when you write something? What are you doing? What are you
tweet out.
sending?
I tweet. I
You
send
tweet
a
it.
tweet.
You tweet.
You tweet
Exactly.
on
You're not going to
Twitter.
try to no, a twit is somebody who's an idiot. I'm not. It's the tweeter, and y'all aren't going to try to convince me otherwise. We're calling John here. Okay, so while we're waiting to get John on the phone, I will call again when I have a pertinent question about the topic. Okay. Well, okay. So
Well,
we
okay,
won't
John.
call John back.
We'll
If
call
you
John
want to
back.
try to call, I don't know why it didn't ring. Let's talk about incompetent medical staff. It's a problem. And it doesn't have to be, it could be a colleague perfusionist. Okay, maybe they have a substance abuse problem. That's a different issue than incompetence. Some perfusionists may actually do a better case impaired. But there's a lot of people in the hospital. There's nurses, there's physicians. And look, I mean, there is a real risk to nothing actually happening to the person, nothing ever really being addressed, swept under the rug, moved, whatever you want to call it, and your career, you're ruined. And that has to change. There's the problem. I think there needs to be real, significant punishment if you just make false accusation that is proven false, but they don't want to do that because that risks people not wanting to say anything at all for fear of that retribution. But the damage that can be done by making a false accusation can be pretty severe. But then there's also, you make you bring up a concern and you end up getting ruined. And that's a big problem. And that exists in politics, medicine, law enforcement, everything else. How do we deal with that? You're a physician, what do you do when you have what does a perfusionist do when they're doing cases for a heart surgeon that they know is just, that they should not be doing heart surgery? What do? Refuse to do the case?
You mean as a perfusionist?
Yes.
Yeah.
Well, I mean, I can't answer that for you. What I can comment on, though, is that if you suspect somebody's impaired, at least from a physician standpoint, then you are mandated to report that. It's mandatory. It's not a question of, well, it's going to ruin a career, ruin somebody. It's your obligation to report that to the medical board or whoever the governing authority is, and it's mandatory.
I think it should be.
Yeah.
I agree with that.
Well, now that we're under the Texas Medical Board,
You should
Because
have the
we're-
same then.
we're held by the same standard.
Standard, right.
Before we weren't, but now licensed perfusionists in Texas, we are obligated. It's not optional to do that.
Right.
But for
But that's
25
impaired. That's such a, that's so, they are or they aren't. Everyone knows what impaired looks like. There's no, they were just hired. I mean, that's nonsense. But let's bring up a case that actually exists. Christopher Dunch.
Mhm.
Let's bring him up. How many complaints were there? He's in prison. He was a neurosurgeon, right? How many complaints had there been before something actually happened? And where's the responsibility? How does that happen?
Well, there are a lot of ways to justify and explain what a complaint may have been brought up in the past. And I think that's what was done. And, unfortunately, the board, for example, is at the mercy of the facts that are reported. So if there's a complaint and somebody comes down and explains themselves and the facts are legitimate enough, then unfortunately, sometimes people get out of those things. But when it got very serious, that particular case, there was a letter written to the board, a complaint, a very long letter, I might add, that had all the facts of what was going on. The board acted very quickly and efficiently.
Mm-hmm. But they have to have the evidence.
more correct. Yeah, facts.
And
have-
there is a fear when you're a perfusionist and you depend on, surgeons for cases, and you get found to be the person who filed a complaint, and that surgeon, nothing happens to them, and now you're persona non grata,
Well,
and your career is ruined for doing what you thought was the right thing, not speciously, not just maliciously, to malign somebody, but legitimate, because you don't operate with the same person. Of course, we do, and you may see things or hear things, but it's secondhand. So it's very hard for physicians when they work so independently from each other to truly police each other.
but I feel like this goes along with something Debbie said, that we're supposed to operate in our scope of practice. So if a surgeon does something that's in their scope of practice, not ours, can we actually judge that decision?
I don't think
And
we have this.
I don't think we're the people that are in a position to make any accusations because of our scope of practice.
I agree. I don't think I have the skill set to say whether a surgeon is qualified. I don't have that skill set. I'm not trained in medicine. I'm not trained as a cardiothoracic surgeon. If I had that concern, I think that I, could speak to another physician so that a physician can then assess that. I mean, that's probably how I would handle that.
Mm-hmm.
And, in historically, in the situation I was in, that's what we did, because this particular, it was a friend, did need, help and did get help. So I agree. I don't think that I have that's not within my scope, but I do feel like we need to speak, and it's hard. It's really
Mhm.
hard, especially
Mhm.
if
But-
then you have
Yeah.
a working relationship with that person.
Same for I think we speak up, but for action to really happen with anything like that, it's really above us in a hospital.
Mhm.
People above us that need to do the right thing and make those decisions.
Mm-hmm. Mm-hmm.
The burden is on them. I think.
Mm-hmm. Mm-hmm.
Do you agree with that?
I don't know. I don't know that I can answer your question. I don't know what I agree with. I don't really know how it's a very complex issue.
Mhm.
And I have at times wavering feelings about it. So, I don't know exactly how I feel. I know it's an issue that is real. It's infrequent, very infrequent, thankfully, but it is a real look. I say this. I don't mean to say it flippantly, but I've been doing this for 40 years. I've seen a way more, very competent, qualified, capable, good to work with, good outcomes, surgeons. And you're right. I'm not a surgeon. This is true, but he's not a perfusionist. He's not a cardiologist. He's not but I think we all know when it's overt, obvious.
Obvious.
That yes, it's not in my scope of practice, but I know that if the guy, if all of
Well,
one
are you saying
person's
that
patients,
they're like that they're, let's say they're, obviously impaired because they're drunk, or
no.
That's
I'm
different.
Are you
talking
talking about
about
because they don't have, they're incompetent because they don't have the skills to?
skills,
Right.
judgment. There's a whole lot that goes into what everybody does in that room. Whether you're not a nurse, but when a nurse is incapable or qualified or competent. When a surgeon's not competent. When another perfusionist is incompetent. I think that part about, well, it's not in my scope of practice is to some degree it's a way out. It's a way
No,
out
it's not
of
a way out. I think you need to ask. I think you need. I'm not saying be silent. I'm just saying I think you need to discuss that with somebody so that you have physician talking to physician.
Well, I think that one thing that hasn't been brought up, and it has been implemented in many hospital systems, is the ethics reporting hotline that you can report anonymously and get a ball rolling. So I don't think
Right.
you have to worry about repercussions for reporting somebody and and an investigation happening and nothing happening to the person you report, that they're going to come back because, quite frankly, they're set up to protect those very people who have concerns.
And that's sometimes a double-edged sword because people
Well, no,
with
it's not,
no
because-
concerns that just want to do it to be to create havoc or
You can
chaos.
say that, but
does
you have
happen.
to have a venue or some way to be able to do this. Now, on one hand, you say you don't want to do it knowingly, and then the flip side is you say that anybody can do it. So, I mean, you either have to accept the fact that you have that a system has been set up whereby if you have a concern with any healthcare professional, not just perfusionists, that you can report these people on an anonymous way, in an anonymous fashion. And quite frankly, the board is pretty anonymous until a certain level, and not worry about repercussions. So
Very
I think
good.
it's the way to do it.
I think it's a very fine line. Like you were saying, if you know a surgeon's incompetent, do you still do their cases? So I can't say, no, I'm not going on bypass for you, or you call me in for an Ecmo, no, I'm not going to do it. But if there's a specific thing they're asking me to do that I know based on what our scope of practice is, what's acceptable.
Or if you know what they're asking you to do is going to do harm.
Well, then I can specifically say no to that thing.
Mhm.
But I can't in general say, I'm not going to work with you if you call me
Right,
in or something like
right.
that. Because I think you kind of asked that question. So
I
that's
did.
where the scope of practice, I think, comes
I
in.
did.
And also like reporting it to people above you that actually do have the means to address the situation.
So I'm just gonna take a hand grenade and throw it at you right now. Having you in your career, you've had a fairly long career for as young as you look, sniffing a lot of foreign apparently. Have you not ever worked with someone who you wish you could have said, no, I'm not doing your case?
Absolutely, but
Okay,
I
fair enough.
haven't said that.
Right.
Right.
We still do it. And I think that is an issue. Let's talk about Ecmo real quick. How much time do we have? The audience left. Anybody over there? How much time do we have?
20 minutes.
Okay, good. 5 minutes. We'll take 5 minutes and then we can break early. On the Ecmo, the trajectory currently of Ecmo utilization is like this. It's straight up and down. Ecmo usage is on the climb, used for a whole variety of things. The trigger to put patients on Ecmo is much earlier now, whether it be a respiratory issue, VV, whether it be circulatory collapse, and basically is a bridge to decision. And Ecmo has it's just becoming more and more popular. All of the projections are that. The growth actually over the past several years has been astronomical. And there are only 4,300 perfusionists in the entirety of North America. That's it, 4,300 and something. Very, very, very small fraternity. One Ecmo, if you were to do 12-hour shifts around the clock, is a minimum of 2 perfusionists. Most programs only have, unless they're in the med center where you have a big system, but most heart surgery is not done in the med center. Med centers, are big places that stand out, but most hospitals, community hospitals, is where all these patients go first. And even the med center can become overwhelmed and have no beds. There's not an unlimited amount of space. So you have to have these community hospitals able to do this. There aren't enough perfusionists now. And what is feared by me is that we are one epidemic away. H1N1 just about broke the back of perfusion. It came real close. We're one epidemic away from not being able to cover it. We have to recruit qualified, competent, critically cared, trained nurses, in my opinion, who can then be cross-trained as ECMO specialists to be able to monitor ECMO in a blended program? If it ever becomes down to the point where they have to initiate it because a perfusionist isn't available, would you prefer someone who was qualified, trained, had been through a course, has done simulations and what is it called, competencies when they have it ongoing, initiate that ECMO, or somebody who just, I'll try. Never done it before, but I'll give it a try. There's where the issue is with ECMO. I think a blended program is best. I think perfusion supervision is important. It is what we do. We are extracorporeal circulation experts. We understand the pump better than, and it's basically a pump, better than anybody else on the planet. But there is not enough of us. And there never will be enough of us. So what do we do? Thoughts?
I think it's going to come down to what each hospital sets as job descriptions. So if you have ECMO specialists and it's in their job description that they can initiate under the supervision, even if it's phone call or teleconference or whatever, under the operation of perfusion, then that's the standard there. If it's just in the standard that they're allowed to just watch ECMO and have to call in perfusionists for these things, it really comes down to what the hospital agrees on and sets as,
What's your personal feeling? How do you feel about it?
I've always felt that perfusionists should be over it and overseeing it and being there for the critical aspects, but we need help with the 24-hour mundane daily care, and that we'll have someone there able to call if there's a problem. That's
Agreed.
how I really feel.
I feel the same way. I mean, there, like you just said, there's only 4,300 of us.
Just double that number.
But you know that's international. I mean, we have some international folks in that are certified as well.
4,300 just it's North America.
Okay. But nonetheless, I mean, that's still not enough for this population.
No, I don't think so.
It's impossible.
Well, I think your key word that you said was trained. I mean, you know, if you go to this canon you were speaking of, I think it was number 3, delegating somebody just to do something in terms of what, saying daily monitoring, you shouldn't do that unless a person is trained and therefore considered somewhat of a perfusionist. You know, I mean, the key is training.
ECMO specialist, not perfusionist. They're going to be. They would be an ECMO specialist.
Well, whatever you name them, you know, but as long as they're trained to do the scope of practice that you guys can do, and that's probably okay. But the way that canon is written, I think is, you know, seems
problematic.
Right, yeah.
Well, you're delegating somebody that's not trained.
Right, and I think that's where that was the comment, and that was where in that particular statement was the part that, you know, you're saying isn't but it said also that wasn't a perfusionist.
Well, it says a trained perfusionist. And the reason that this
Trained
one's conflicted
perfusionist.
for me is because the program that I participate in is a hybrid model. So perfusionists initiate and then transition to a nurse respiratory therapist based specialist that sits the pump. They're trained. We have annuals, we have buddy runs, all of that. But the perfusionist actually initiates and then is available on call for any emergent situations. However, the program now is considering transitioning where the perfusionist wouldn't have to be there for initiation. And when I read this, I'm like, according to this, if you take it word for word, am I in, you know,
I think if we do that, we lose ECMO. I
Mm-hmm.
think if we start allowing that, we lose ECMO altogether.
I agree with you 100%. So what is the reason that that's happening at that program?
The reason it's lack of perfusionists. That's a neonatal pediatric perfusion model, and the pediatric perfusionist, the CV part of it has just grown, have added new surgeons, And so just having perfusionists available to actually respond. And again, they're going to an ECPR model, so they want to be able to respond ECPR. Well, then you're going to have somebody basically in-house.
Mhm.
So
Yeah.
having a perfusionist in-house 24/7 is impossible. So how are we available supervising, like you say, by phone, by, being available to come in if they need you, and that hasn't happened yet, but there's discussion about moving towards that. But I participate in a model similar to yours, and
I think this covers you as long as you qualify the person that you're going to
Mhm.
have, because it just says you shouldn't delegate to a less qualified person. So if you train somebody that is equally qualified, even though they may not be called a perfusionist,
right.
then I don't think you're violating your code, and I think that you ensure patient safety as well by doing that.
So someone from Facebook made a comment, I think. Rebecca Balkovac. Not all facilities, hi Rebecca, not all facilities operate with multiple physicians. Very true. There's a lot of single surgeon programs out there. To compare, and sometimes we see from an administrative perspective, few people with cardiac experience, thus leading to situations of not knowing where to turn as far as not wanting to ruin someone's career if you say something out of your scope of practice, or potentially ruining your own career with the possibility of retaliation. Yeah, that's what we just discussed
Agreed.
that. Yeah, absolutely. But I agree. We agree with you, Rebecca. It's an issue. Here, give Batchick his phone back. Thank you though for the comment very much. And okay, so I think we've beat everything up.
Yep.
Does anybody have any final thoughts before we close this session out and then get ready for our next session?